Để bắt đầu chương trình, chúng tôi xin mời Thạc sĩ bác sĩ Phạm Văn Chính báo cáo trường hợp đầu tiên. Xin mời.
Good afternoon, Chairman and all colleagues. I'm very honored to be here to share with you my presentation. Okay. My patient is a case of acute myocardial infarction with no reflow phenomenon and cardiogenic shock SCID after PCI. Let's get started. My patient is a female, 68-year-old with history of diabetes and mellitus type 2. She uses 10 units of long-acting insulin per day. She admitted to the ED because the chest pain. Her symptoms started 3 days before, and 2 hours before admitted to the ED, she feels very tiredness and sweatiness. So she comes to the ED. The ECG shows us ST elevation from V2 to V5, and the echography shows that echinacea motion in anterior septal and back. The EF is 46%. The blood test shows elevated cardiac enzyme with troponin T were 2599 and CKMB and proBNP also elevated. And the coronary angiography shows that you can see the left circumflex is normal, but it is a small vessel. And in another view, we see the lesion in the LAD with very slow flow in the detail. And you see another view. You see that the right coronary is normal and it is a domino vessel with some collateral to the LAD through a PDA artery. So what's the next step for this patient? It is possible to intervene with the lesion. So or should we be optimal with medication because patient have symptoms 3 days ago? And if we do PCI, the tactic for PCI procedure and what we do to prevent complication. So we discussion and agree that the unstable lesion patient with high risk of total occlusion of LAD. So we do PCI for her. This is the procedure. I'm interventionist, not interventionist, so I don't focus on more on the intervention. We just balloon the LAD from the mid to the proximal. But you can see the flow of the LAD don't improve very much. So we use another view to confirm that we all widen the proximal of the LAD. So the tactic for place stand, because it is a long lesion, so we choose stand. First stand for the distal, the mid, and first and second stand for the proximal. When we inflate the balloon, you can see the flow didn't improve. So we put another stand, the second stand, to the left main to the proximal of LAD. And the story begins. When we standing for the proximal of LAD, you can see the no reflow phenomenon, and the heart rate of the patient down quickly, and the blood pressure also very low. So patient have phenomenon no reflow. You know that no reflow phenomenon is one major complication, and it is associated with increased mortality in STEMI undergoing PCI. And no reflow can occur in both ACS and stable patient. and due to the structure and functional of the coronary microcirculation. And no reflow have been described up to 60% of STEMI patients with optimal coronary vessel reperfusion. There are some modality to diagnosis of no reflow, but in clinical we usually use TB frame count to diagnose this no reflow phenomenon, and the TB count less than 2 no reflow, and the consequences of no reflow phenomenon can lead to expand infarcti and can induce ventricular arrhythmias and acute heart failure. And there are some clinical risk factors for no reflow, such as OS, hypertension, smoking, renal failure. But my patient have just one risk factor. She is 68 years old, and there are more medication to manage no reflow phenomenon, such as adenosine, sodium natriuretic, calcium channel drugs, or antiplatelet, or epinephrine. So what we do for our patient? Because patients have bradycardia and hypertension and dyspnea, so we use first atropine 1 milligram to intravenous. After that, we use vasopressor and inotrope to raise blood pressure. To support your respiratory system, we use non-invasive ventilation for her. And for the coronary, we use adrenaline, adenosine, and nicardipine, and the result. After adrenaline, intracoronary 1 time, and adenosine 3 times, and nicardipine 6 times, you can see the coronary flow very slow, and the wall motion of the LAD not improve, and symptom of patient worsening. So my colleague told us they don't have any method to do with this patient. So patient transfer quickly to the CICU. And you can see this is the picture we use for this patient with CI 1.4, and the extra long water E20 is almost 3 times for the normal. And the echo shows us a kinesia on the septal and the apex, and hemodynamic very unstable. But we use inotrope and vasopressor to keep the blood pressure to reach the target. And after we think that we need to use some mechanical circulatory support for her. And there are many kinds of circulatory support device, but in our center we just have IABP and ECMO, Tandem Hub and Impella we don't have in Vietnam. And in this patient, we see that she have left ventricular dysfunction. So I don't want to raise the afterload. So first we use we think we use IABP, and more which is bad or better or for this patient. But in the ICU, she also developed anuria. We use furosemide bolus and furosemide infusion, but after 6 hours, the urine output just 90 millimeter, and the urine sodium concentration just was 38, and the acidosis come, and pH is 7.15, and the lactate is 8.5. So we combine with hemodynamic unstable, so we ask CRT for this patient. You can see in the chest X-ray, the patient have very much of the congestion, the pulmonary edema. So we intubation for her. And GD my management for her with IABP and CRT and vasopressor and mechanical ventilation. And the results today support by mechanical security support, all vasopressor and inotrope was slowed down the dose and stopped it. Today following IABP and PICO were winning. We H2 for her, and 10 days next we optimize the medication. She discharged our hospital at 17 days, and you can see the journey of patient. She come back to our department to regularly check up, and everything will normal. This is my patient, and in with my patient, I will want to send a message that we CICU always stand by and always back up for you, interventionist or cardiologist, and the role of shock team is very important today. Thank you for your attention.
Thank you for your presentation. May I invite Dr. Lam Ho for a comment?
Yeah.
Please.
Thank you very much. Excellent presentation. And the case illustrates one point. That is the use of IBP for no refill. I absolutely agree with this point. In my personal experience, I also found that IBP can be useful in malignant no refill. The mechanism probably is you increase the blood pressure and then it provide stronger pushing force, because sometimes no refill is not just the problem of microvascular dysfunction, it's also the problem of systemic pressure. If the systemic pressure is too low, probably the MCS can help. And nowadays, in tomorrow I will present some case, some situation. I found that now they probably Impella even work better than IBP for no refill. Yeah.
But in Vietnam, we don't have Impella. Yeah.
But it's smart not to put ECMO, because probably the afterload is too high and vascular complication and all the other things. It may kill the patient later.
Yeah. Thank you.
Thank you so much for excellent comment from Dr. Lam Ho. And we would like to have one more comment from Vietnamese expert. I would like to invite Dr. Ngô Minh Houng.
Thank you very much for asking me to give the other question. I just have a question for you that in this situation, why did you use the one stent instead of two stents in order to like a faster procedure, and before that we do the suction, like a thrombosuction, in order to take it out some thrombus in order to limit the slow flow after we implant the stent?
Yeah, thank you for your question. Because I'm in a CICU team, so I discussed with my colleague, the interventionist. He says that the reason quite long, so he want to do it safety, so he choose stent, and one for the mid and one for the left main and the proximal. Maybe I will says to him that we need to use a long stand to place stand one time. Maybe it can don't happen no reflow phenomenon.
Can I just one comment? So I think in this case, you have to assess what is the reason why the patient has no reflow. Distal embolization is one of the causes, but I think this patient has a late presentation. So one of your reasons for no reflow is late presentation, because it causes myocardial infarction, causes myocardial edema. So that's why the capillaries are being compressed.
Yeah.
That's the reason why. I agree with Dr. Houng that I think the mid part actually not too tight, and it's just the proximal part which is the lesion. So in MI patient, a STEMI patient, the less metal we put in, the better. And you already have no reflow first. If you put a stent in, the chance of no reflow even higher. So for me, I usually give some intracoronary dilator first, adenosine, to make sure the flow is better first before I put stent. Because if you already no reflow, put stent in is not going to help. And lastly, I think the medication that works for me usually is the intracoronary adrenaline, which actually helps the no reflow a lot. For some reason, the contraction actually can squeeze out some of the clots down, capillaries.
Thank you for sharing. Yeah.
Okay. Thank you so much, Dr. Phạm Văn Chính, with a very challenging case. And we would like to move with the next speaker. We would like to invite Dr. Nguyễn Thế Quyền.
Good evening, members of the panelists and all the audience in this section. Today, on behalf of the Thống Nhất Hospital Cath Lab team, I would like to introduce a case that represents the cooperation between the two interventional teams in my hospital. The first is the coronary interventional team that will deal with the coronary stenosis. And the second team is the neurointerventional team that will deal with the coronary artery aneurysm. First of all, we will have a quick review of the patient. It is a 71-year-old male patient with the history of hypertension and dyslipidemia, presenting with a chief complaint of multiple episodes of angina at rest, lasting from 5 to 15 minutes long each, and self-subsided. At the day of admission, the patient had a severe, sustained 1 hour long angina, so he seek medical care. At the ED, the ECG showed an ST depression from V1 to V6, as we can see. And the high sensitive troponin T level was 760 picogram per ml. And the echo showed an anterior warmth and apex hypokinesis, with the LVEF being 48%. So with all of the information, the patient was diagnosed with a high-risk non-ST elevation, MI, and therefore was indicated to perform a coronary angiogram. The right the RCA angiogram showed a 70 to 90% stenosis at the middle segment, 80 to 90% at the distal segment, and 70 to 80% stenosis of the RV ostium. The left coronary angiogram showed 40 to 50% stenosis at the distal segment of left main, 80 to 90% stenosis from the proximal to middle segment, 70 to 80% at the distal segment of the circumflex. The LAD was noted with a 70 to 80% stenosis from the ostium to proximal segment, 40 to 50% at the middle segment, and a remarkable 4.8 by 4.3 millimeters circular aneurysm at the proximal segment of the LAD. So combining with the clinical picture from the echo and the ECG, we can easily assuming that the LAD would be a culprit vessel in this non-STEMI case. So we decided to firstly revascularize the left coronary system. The circumflex iris show a diffuse significant stenosis from the proximal to the distal part of the circumflex, with the plaque burdens being around 60 to 70%. We also noticed a non-significant stenosis of the ostium of the circumflex, with the plaque burden was about only 30%. Since we plan to put a stent from left main to LAD, so we decided to do the PCI at the circumflex first. The lesson was pre-dilated with a 2.75 scoring balloon, and then we put 2 drug-eluting stents, the 2.75 and the 3.0 DES, from the proximal to the distal part of the circumflex. And then we post-dilated with a 3.75 NC balloon. And this is the final result of the circumflex. The post-stent IVUS show an acceptable stent expansion with the distal part of the HSIC have the MSAs around 8.4, the middle part of the HSIC with the MSAs around 12.5 millimeters square. The next step is to deal with the lesion at the left main and LAD. On the IVUS, we can see that there is a significant stenosis at the proximal to the osteo-LAD with a plaque burden were being around 60 to 70%. And at the distal part of the left main, the plaque burden was around 54%. And we also noticed a large aneurysm at the proximal part of the LAD. So how much do we know about the coronary aneurysm? To date, data relating to this kind of lesion and its management are limited to the case reports and case series. An article review on HSIC in 2018 has proposed an algorithm to manage this kind of lesion. Depending on the presentation scenario of the patient, the review proposed 3 ways to manage the coronary aneurysm. Our patient admitted with an ACS having an aneurysm associated with a stenosis. So the solution comes down to a cover stent or a stent-assisted coil, depending on the lesion characteristic. An aneurysm with a risk of side brain loss, vessel tortuosity or calcification is not a good candidate for a cover stent. In our patient, we can easily see that the aneurysm is at the proximal part of the LAD, near the left main bifurcation. And there is a large diagonal branch in this area. So the risk of losing this diagonal branch and maybe even the circumflex is high if we use a cover stent here. Moreover, the LAD is quite tortuous and moderately calcification, as we have shown on the IVUS. With these reasons, the stent-assisted coil technique seems like a reasonable option to deal with this coronary artery aneurysm. Okay. This technique is adapted from the neurointerventional specialty when they deal with the intracranial aneurysm. In this technique, they used a microcatheter to deliver coils to embolize the aneurysm with the assistance of a balloon or a stent in order to prevent the coil from falling out to the vessel lumen. So this is how we have done. First, we deliver a microcatheter through a wire into an aneurysm. And second, we through the microcatheter, we deliver 3 coils to embolize the aneurysm and to fill up all the space of the aneurysm. This is coil number 1, coil number 2, and coil number 3. Okay, and this is the results. The results after the coiling was done. The next step is to put a stent to the left main LAD lesion. First, we pre-dilated the lesion with a 2.75 scoring balloon. A 3.5 DES is delivered to the proximal part of the LAD. Since we know that the ostium of the circumflex is intact, as we have shown on the IVUS, so we decided to use one stent technique on the left main LAD lesion. So we use a 4.5 DES to put a stand from the proximal, from the ostium of the left main to the proximal LED. And then we post-dilated the stand with a 3.75 NC balloon on LED and 4.5 NC balloon on the left main. The IBUS was done one last time. We can see here that the stand expansion is acceptable. With the ostium LED, MSA was around 10.1. Distal left main, the MSA was around 13, and ostium of the left main, the MSA was around 17.5 millimeters square. And we also see the coin at the streak of light. It is the streak of light that's protruding a little bit into the lumen of the LED. It is the coin. Also, and this is the final angiogram of the patient. This case has marked an achievement of a good cooperation between the coronary and the neurointerventional team of our hospital. I hope you guys enjoy the case. Thank you for your attention.
Thank you, Dr. Thuong. Because we not enough the time, and I think we remain a very interesting case behind. So one presentation, we would like to invite one Vietnamese expert and one international expert. The first, I would like to invite Dr. Dinh Thuong.
Thank you for sharing an interesting case. Actually, I have to say that I have no experience of using coil for aneurysm. Yeah, the only situations that I use coils is to treat the distal perforations for patients. So my question is that how big of the aneurysm that we can coil, and then how to decide to choose the coil, how many coils should be put in, any criteria on the angiogram that we use to define that we use enough coil, or we just put in, and then, yeah.
Okay, thank you for your question. As I have mentioned above, the treatment of this kind of lesson is just limited to case series and case reports. So about how big of the aneurysm, I think the article review has they say that when the aneurysm is too big, about more than 20 millimeters in diameters, the choice of therapy must be the CABG. But when the aneurysm is about 4 millimeters in diameters to the 20-meter diameters, that's we can use the coil, because with that big of the aneurysm, there's a risk of forming emboli in the aneurysm, and then causing the STEMI or non-STEMI intubation. So for the question is that how many coils can we use? There is no consensus. Honestly, there's no consensus of using this, because we have adapted this technique from the neurointerventional team. So
xin thông báo, báo cáo viên chỉ còn 2 phút trình bày. Xin cảm ơn.
This is honestly, it is up to the experience of the teams to put the coils, and I think that they put when they give the number of coins they give will be at the time when we don't have any contrast that can go into the aneurysm.
Okay, thank you. And the next comment, we would like to invite Dr. Liew from Malaysia.
Thank you for a very good presentation. Successful with your plans. What if the procedure was not successful with coiling? What would be your plan B?
Thank you for your question. I think when the coil is failed, the final option would be surgery, of course. to seal the cord, seal the aneurysm, and maybe the complication of this procedure maybe is the perforation of the vessel. So maybe the last results will be the cover stent in order to save the patient first.
Yeah. So covered stent, but what is the complication of the covered stent in this situation?
Sorry?
What would be a potential complication of a covered stent in this situation?
The cover stent in this situation, like I said before, that can have a loss of the side branch, like a big diagonal branch in this case, or maybe the circumflex.
Yeah, very, very true. And if that happens, is there anything we can do about that?
I think that
you're doing very well. But I think my line of question is basically for every interventionalist. We have a plan A, and we always have to think about a plan B and sometimes a plan C. Okay. And some of these things we may not encounter all the time, but we come to meetings like this and we learn from each other and we read. Okay. So there has been a report about putting a covered stent and then perforate the covered stent to re-establish flow to the side branch. So there is a plan C.
Okay. Okay, thank you for your comment.
Thank you, Dr. Nguyen, for your very interesting case. We will switch to the next presenter. May I invite Dr. Minh for his presentation.
Good afternoon, Chairman, Church, and all college. To be honest, I'm happy to stand here to share the case in this afternoon. So what we have today. So we know that about the ping-pong guide catheter is useful in some situation. So I bring a case, just an example about ping-pong guide catheter facilitate real-time IVUS to PCI the stemless CTO. So what we have today, we have a patient, 50 years old male. He came to hospital because of the chest pain when he walked one flight of stairs. And past history, he have hypertension and he also a smoker. And we do the EKG. The EKG show ST depression, horizontal depression at the V4 to V6. And slightly elevation at AVR. And the coronary CT scan show total occlusion at the proximal LAD. And the RCA and circumflex is okay. But interesting, this case, the CTO ended at the, before the carina point, a little bit, just around 1 millimeter. And further investigation show echocardiography, the LVEF is 57% and have a large ischemic burden on stress echo. So let's move on to the coronary angiogram. So my young junior, he asked me about where is the occlusion site. So everybody can see at the proximal LAD, so to see clearly about the occlusion site, so we do the simultaneous injection. So let's see again. To go this entry point of the CTO with the arrows, but it's not easy in this situation. In this situation, the CTO ended at the bifurcation and ambiguous. So in this situation, to increase the chance to be beside the CTO, we have to something assist. Especially, ideally, I think maybe the real-time IVUS will be the good choice in this situation. But let's come back to the funny story. How can we put the elephant into the refrigerator? We have to open the refrigerator, right? But not just easy how big of the refrigerator. The second, how can we put the graph into the refrigerator? We have to pull the elephant out, and then we push the graph in. Or we have another option is we have a bigger refrigerator, we have a French, or we have another refrigerator. We have another guiding. So in my case, we use the double catheter. We use another guiding to use the IVUS real time. From the left radio, I approach with the JL 5 frames, and the right radio, I use the EBU 7 frames to do the real time IVUS. In this case, the lesion, according to the CT scan and the IVUS, is not too calcified. The length around 20 millimeters. So I put the IVUS tip at the proximal cap of the CTO, and it's jump backward and forward, follow the heartbeat, so we can see the before and after proximal cap, and then we use the Gaia second to puncture the proximal cap. So it's very important step. And when we saw the pictures, this pictures is wonderful. So almost the guide wire already in the true lumen. So then the guide wire was advanced to the distal in the CTO body and to the distal. But now it's hard to push the guide wire past to the distal cap of the CTO. And then we escalate to the Gaia third for stiffer and stronger. So luckily, the Gaia third was advanced successfully to the diagonal branch. So the manual rotation is so the Gaia already in the true lumen. So then we advance the microcatheter and tip in check, and we check again. Now we remember again the CT scan show the CTO is ended before the carina. So we have many strategy in this state. So we choose the option, we use the small balloon with low pressure to predilate and wiring to the LAD. And then we check with IVUS, we do the professional stenting, and we push the stent with the size 4040 at proximal to mid LAD. The flow is good after the procedure. So what we have today, right? The bottom line is ping pong guide catheter is simple, but it's useful in some situation. At the Archimedes, he quite confident. He say, give me a fulcrum, I will move the earth. But the intervention the BCI man, he quite humble and say, give me more space, I will do something interesting. We can do something interesting like real-time IVUS to puncture the ambiguous CTO or summit CTO. We can use ping-pong guide catheter to do ultra-low contrast BCI. We can use the real-time IVUS to do another like we can rescue the rotabur when it's entrapped in the calcified nodule, and we can do trifurcation kissing, and especially in the case we have a massive perforation, it can help us to deliver the stent cover stent to seal the perforation. So one day when we need to push more device into the coronary to assist PCI, let's think about the ping pong guide catheter. Thank you very much.
May I invite Dr. Houng for the first comment?
Thank you very much. Thank you very much for asking me to give a comment on this situation. Congratulations for the very interesting CTO with the stemless LED CTO. And I just have a question that do we need to use the IVERS all the time for this kind of lesion or not? Because this one is the stabilize of the guiding is the most important in order to find the ostium of the CDO. So in this situation, sometimes I use another Y at the circumflex and one Y in outside the left man in order to point the guide into the ostium of the CDO, and then we can find the ostium by that way. In this situation, you use the IVERS in order to look at the ostium is a very good technique, and of course we sometimes the moving of the IVERS is the most important thing that we have to stabilize that, because it keeps moving, so we don't know where to poke the proximal cap. And then another question is that for example, you fail to do this one, so how to deal with this? For example, anti-grade techniques, you fail already, so how? What is your plan B? Like Dr. Liew just said that, okay, plan B is what?
So thank you for your comment. So in case I fail to do this case, maybe another option is next time. But we thinking about how we fail. Depend on if we go to the dissection, or if we cannot punch a proximal cap, or we fail at the distal, and depend on the reason. But at the time we try to fix it, but the procedure time or contrast, everything long too enough, I will stop the case first, and we get advice from the senior.
Yes, actually you have the very good collateral from the right to the left side. So I think in case that you fail to do the anti-grade approach, so we can go from the right side, go back to the ostium of the LED with that technique. So I think in this situation you did a very good job for this situation for the CDO. And you have also you recommend how to use the ping pong technique as well. That's the learning point. Thank you.
Thank you very much.
Thank you, Dr. Houng, for your comment. May I invite Dr. Aaron Wong for his comment?
Thank you. A great case, but I just cautions about when you cross the wire into the diagonal. Even though the CT scan show that diagonal is connected to the LED, but your entry point to the diagonal could be above the bifurcation. So it's very careful if you want to dilate it, because the moment you dilate it, the flap actually will close the LED and you will not be able to enter the LED. So it's good to put a microcatheter down, do a distal injection. If you see the dye reflux back to the LED, then these two are connected. Then you may be able to use a balloon to open up the channel, or do a reverse wiring to go to the LED, so that you can wire the LED. So in this case, actually you went through the true lumen. So when you open it out, the LED can be wired. But sometimes you may not be that lucky. So sometimes the LED may get closed. So I think it's a good case. Yeah.
Okay. Thank you very much, sir.
Thank you, Dr. Wong. So now we switch to the last case. The last but not least, may I invite Dr. Trần Văn Đông for his presentation.
Ladies and gentlemen, it is my honor to be here today representing our interventional team at Hanoi Heart Hospital to present an interesting case regarding complication in coronary intervention. Our patient was a 68 years old male admitted to the ED because of typical chest pain. His history include hypertension, diabetes, and prior smoking. On ECG, we see that he had SC elevation on D2, D3, and AVF. On flash echo, he had preserved ejection fraction and no pericardial and pleural fluid. So we came with the diagnosis of SC elevation, myocardial infarction, and the patient quickly transferred to cath lab for angiogram. On angiogram, we can see that the patient has kind of a mid to severe stenosis at the proximal of the LAD and a acute total occlusion of the RCA. And so the culprit lesion here is RCA, and it is just a mediocre case. And we decide to revascularize RCA. Using radial access and a hydrophilic guide wire, the flow was easily restored after inflate balloon to 2.5. And then we placed a 3/5/48 stent. And after stent deployment, there was somewhat of slow flow phenomenon, and we successfully managed it with adenosine intracoronary infusion. And this is the final result. As you can see that the flow was TME3, and the stent had good expansion. But after 30 minutes, the patient developed a refractory angina with increasing in intensity, but no hemodynamic disturbance. And we do echo, and we found no pericardial fluid, and also no alteration in ECG pre and post PCI. And it raising a question, the first question popping out was, is that in-stent thrombosis or stent occlusion? So we take the patient to angiogram again the second time. And here you can see there is a perforated point from the distal of LCA, possibly causing by guide wire, and it's caused a little pericardial effusion. So we try to embolize the distal part of RCA using coil. The first coil was failed, but after the second point, the second coil deployment, the perforated point has been totally occluded. And we follow up the patient again, and the second time the patient developed refractory angina. And on repetitive echo, we found a relatively small amount of free pericardial fluid. And that time is different from the first time, is that hemodynamics started to deteriorate. And so what is the cause of this problem? Is that in-stent thrombosis and stent occlusion, or another occluded branch, or iatrogenic aortic dissection, or there is early signs of free wall rupture? We don't know, and we have to find out. So first we do aortography, and we can see here that there is no signs of aortic dissection. And the second thing that we do at that time is try to embolize the perforated branch. And you can remember from the first angiograph that there is some kind of collateral circulation, probably from the septal branches of the LAD to the RCA. So that could be the cause of fail to embolize the perforated branch by coil, because it kind of forming a blood pool that were fed by both RCA and LAD. So we think about some substance that can push to that pool, and we attempt to use sponge gel. And after sponge gel embolization, you can see here is that the perforated branch was totally occluded, and the final angiogram show good flow with no contrast outside the artery. But then accidentally we found that the left pleural space was full of free fluid, which then immediately drained it. We don't know where it came from, but we have to drain it to remove it away from the pleural space. And about 2 liters of bloody fluid has been removed from this patient. So the question is, where had all of it came from? And that is the image when we fully drained the pleural space. And when the pleural space is out of free fluid, it kind of having a negative pressure. And then we can see here is a flow from the pericardial space to the pleural space. And we think that there must be some connection here, some connection between the pericardial and pleural space that can drain all the bloody fluid from the pericardial to the pleural cavity, and so it causing acute loss of circulation volume and also occupation of fluid in the left pleural space, and all of this causing symptoms of the patient such as chest pain and hemodynamic disturbance. And now the story is clear, and we have to manage it due to what we understand. What we understood here is that free up the pleural space by pleurocentesis and replacement of circulatory volume by high molecular fluid and blood transfusion, and also careful follow-up to detect any signs of abnormalities. And then after that, the patient was rapidly stabilized and discharged after 3 days. And so we found that pericardiogenesis is a kind of result of failure of pleural pericardial membrane to fuse completely on one or both sides, and with the reported incidence of less than 1 per 10,000. And its actual incidence may be higher because mostly it's asymptomatic, and it can be partial or complete absence of the pericardium. And in our case, it was a partial absence of the pericardium in the corner of the pericardium that connect the pericardium and the pleural space. So what the lesson from this case is that we have to always prepare for the abnormalities and variation in clinical situations, and step-by-step management is crucial when confronting PCI-related complications, especially when the hemodynamic is unstable. And we have to assess patient in every perspective and should not be focused on a specific system or organ. Thank you so much for your attention.
Okay, thank you so much. Very interesting case. The first opinion from Edward, I would like invite to Dr. Fazir Omar from Malaysia.
Well, thank you very much for sharing the case. It's very interesting. So I think there will be 3 points I want to highlight. Number one is there's never ever a simple case. So the only time when it's simple is when this case is done and patient's gone back home safely. Number two, I think it's very important that you showed the steps to understand when they are decompromised, they get unwell, is to know what's going on, all your logics in your thoughts about, you know, whether is it going to be a perforation, how you treat the perforation, and all that. My only third point or my question to you is that when he had the hemodynamic compromise, from the echo, was there a cardiac tamponade or there was no tamponade because there was a fistula when his BP was low?
Yes, we do echo many times, but we only found a relatively small amount of fluid, just about 1 or 2 millimeters, and this cannot be the cause of hemodynamic disturbance in this patient.
And how long after the procedure patient had this compromise in the blood pressure?
After 30 minutes, the patient developed the first symptoms, but just chest pain and a little bit feeling unwell. But after about 2 hours after the first procedure, the patient started to develop disturbance in hemodynamics.
So the timing is also very important. So if you have anyone who's got a tamponade or compromise in like the first half an hour, it must be a large vessel. You can see very clearly. If it's much later, and if it's like 2 hours or 3 hours, maybe a semi-mid branch. 5 hours later, a very small distal PL or PD branch. So that the timing, at least you can think where is the source coming from. But a very interesting case. Thank you.
Yes, thank you.
Okay, thank you.
Can I just make one comment? I think the most important lessons learned here is that once you finish the procedures always see longer because I saw that after you finish, there is a contrast staining in the pericardium. So you have noticed that there is a perforation at the end of procedures. Yeah. Secondly, that if you know that there may be collaterals from the left coronary system, you should have done the left side to see whether there is any more dye staining there, because you have sealed off one side, but the other side may not have sealed off. So that may have contributed to the effusion. But a very interesting case. Yeah.
Okay, thank you. And the last comment, I would like to invite Dr. Liew from Malaysia. Very interesting case. So you receive many comments from Edwards.
Yes.
Thank you. Actually, I actually want to make a comment Aaron has actually made. There was already evidence of bleeding after the stent. I think the lesson learned here is CTO wires are always dangerous. After we cross it, we should change it to the soft wire. When we maneuver balloons and stents, sometimes very important to keep an eye on the distal end of the wire. Especially sometimes when we zoom in, we don't see the distal, and then all this maneuver, the wire can actually perforate. But you illustrate a very interesting case of hemopericardium and a hemothorax. I think the bleeding was there, but it did not have tamponade because the blood was spilling into the hemothorax. Until such time, then the pressure starts to build up, and then the pericardial, tamponade effect came on. So it was a lot of blood, 2 liters, a lot of blood. That is enough to cause a hemodynamic compromise. But very good sharing.
One more question is that how do you deal with the heparin in this case when you recognize there is a bleeding there? Do you heparin?
Yes, we use a standard dose of heparin about 100 per kilogram. Because of this, I have to comment that this lesion is not chronic total occlusion, but acute total occlusion with SC elevation. And in this situation, we have to use full dose of heparin, about 100 units per kilogram for intervention.
Okay, we have 10 minutes late, so I think that I will conclude the session. Thank you very much for your last presentation.